Next topic is cardiomyopathy and classification and approach. ESG guidelines. Dr. Ashok Kumar, he is MD, DM, Senior Interventional Cardiologist from Patna.
Good evening, respected chairperson, present August audience. Myself, Dr. Ashok Kumar, at the outset of my talk, first of all, I would like to thank organizing committee HIC, especially Dr. Alok, who has given me this opportunity and decided this topic. Actually, when he gave me this topic, I was a bit confused and what to talk about. But when I went to the literature, then I found this is the first guideline that has classified cardiomyopathy. Why so? Because the prevalence of this disease is not so high. And that's why there is no definite randomized control trial. So most of the evidence came from level C, not level A or level B. So, what is cardiomyopathy? Cardiomyopathy is defined as myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular heart disease, and congenital heart disease sufficient to cause observed myocardial abnormality. And but still, we are using such terms like hypertensive cardiomyopathy, we are using ischemic cardiomyopathy, alcoholic cardiomyopathy. These terms are still in use. And as the knowledge increases, as the genetic amplification or genetic testing is being done, lots of thing is coming. What is new with this classification? European Society of Cardiology guideline classify cardiomyopathies based on the morphofunctional phenotypes and recommend a systemic multi-parameter approach to diagnosis and management. And it involves not only cardiologists, apart from cardiologists, it requires nursing staff, it requires different subspecialty like neurologists, nephrologists, because most of the genetic form of cardiomyopathy involves different organ. That's why it took help from other subspecialty. This is the historical classification of cardiomyopathy that has been subdivided based on the etiology like hereditary cardiomyopathy and acquired cardiomyopathy. And traditionally, we use three term restrictive, hypertrophic, and dilated cardiomyopathy. Not all cardiomyopathy, and many a time we will see the patients of hypertension having abnormally increased left ventricular mass. So it is not necessary that the patient is having only one disease. That might be a case of hypertrophic cardiomyopathy and having hypertension. So don't confuse with only morphometric presentation. And one newer thing that has been incorporated in this morphophenotypic based classification by European Society of Cardiology, they have included a newer term, that is non-dilated left ventricular cardiomyopathy. Earlier, we used to classify this also in heading of dilated cardiomyopathy. Many a time we see in echocardiography the LV is not dilated, still there is global LV dysfunction and ejection fraction is very low, and we still used to write this entity as a dilated cardiomyopathy. But for those, they have included a newer term, that is non-dilated left ventricular cardiomyopathy. Other are hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, and restrictive cardiomyopathy. This is also a debatable term, that is arrhythmogenic right ventricular cardiomyopathy. It could involve right ventricle, it could involve left ventricle, it could involve both ventricles simultaneously. So nowadays there are some term in vogue is AC, arrhythmogenic cardiomyopathy hyphen LV if it involves predominantly left ventricle, and RV if it involves predominantly right ventricle, because most of the presentation of this entity is usually arrhythmias or sudden death. So, morphological and functional trait used to describe cardiomyopathy, morphological traits like ventricular hypertrophy, ventricular dilatation, is non-ischemic ventricular scar, and other myocardial tissue characterization features on cardiac magnetic resonance imaging. functional trait like systolic or diastolic dysfunction. Diastolic dysfunction predominates in restrictive pattern. And coming to the etiology and pathogenesis, there are genetic cause that could involve sarcomere mutation. Most of the hypertrophic cardiomyopathy, about 50%, are Mendelian autosomal dominant type, but polygenic is also there. In ARVC, desmosomal mutation, channelopathy, and many storage diseases. And coming in acquired causes, it involves ischemic, myocarditis, toxin, and infiltratives. Many a time, the terms like alcohol. Alcoholic cardiomyopathy present like dilated cardiomyopathy, but not all alcoholic develop cardiomyopathy. And after some analysis, it was found that one third of these alcoholic cardiomyopathy diagnosed as a genetically mutation of TTMP. Epidemiology, uh, prevalence wise, hypertrophic cardiomyopathy is still having 0.2% prevalence, and it is more common, but DCMP has regional variations, because in our part, I am from Bihar, dilated cardiomyopathy is more common rather than when I was in Lucknow. There is regional variation in dilated cardiomyopathy also. Another least common are less common, like non-dilated LV, ARVC, and RVC. A special population like alcoholic cardiomyopathy, cancer therapy-induced cardiomyopathy, peripartum cardiomyopathy, acute myocarditis, and it all have some second hit theory. So these are the different way how to they different guidelines having class of indication and level of evidence. So why we need multidisciplinary care for cardiomyopathy? It involves this guideline has advocated to do and to have multidisciplinary care, like having cardiomyopathy specialist that includes cardiologist, a specialist nurse, cardiac genetic counselor. Apart from patient support is very important, because if you are labeling someone or doing genetic cascade, and for relative you are labeling that he or she may is having some genetic modification, they need some psychological counseling also. Apart from that, other subspecialties and multidisciplinary team approach is class 1 evidence, but level of evidence is still C, because we don't have much randomized control trial. Timely and adequate preparation for transition of care from pediatric to adult services, because most of the time that these even hypertrophic cardiomyopathy doesn't present below the age of 6 years. It mainly present in adolescent and middle age, and if the patient survive this middle age, the prognosis is almost good. So these are the key aspect of evaluation and management of cardiomyopathy. So patient's pathway, we have to take care of symptom, incidental finding, and family screening if the patient is being diagnosed morphologically as a cardiomyopathy. So in this pedigree analysis is important, and normal routine investigations like ECG to see arrhythmias, echocardiography for morphological classification, and nowadays MRI is very important tool to help that it may lead to tissue characterization, and gadolinium enhancement is very important to categorize, because there are different pattern of different disease of gadolinium enhancement. Earlier there was very much concerns about using gadolinium in renal dysfunction patients, but now newer linear gadolinium or newer machine, the incidence of fibrosis or renal dysfunction with gadolinium is almost negligible. So you can safely go for gadolinium enhancement if patients having EGFR more than 30, and that will help in making the clear cut diagnosis of different subtype of cardiomyopathy, even in myocarditis. So presentation will be either arrhythmogenic or heart failure. So systematic evaluation using multi-parameter approach is class 1 level of evidence C. and family history, and that for 3 and 4 generation of family tree is important to establish the diagnosis. So systemic approach for phenotypic based integrated etiological diagnosis, multimodality imaging. So it includes all. First and foremost is clinical detail history, then echocardiography, and then for tissue characterization, cardiac MRI. Sometimes you may use CT or PET scan for diagnosis of different storage disease. Yeah, so recommendation for cardiac MRI. So initial evaluation is class 1, level of evidence B. For routine and follow up, you can repeat cardiac MRI for 2 to 3 years to see the progression of the disease, but not routine and yearly MRI is recommended. Yeah, these are the different pattern, and this pattern is very important to diagnose the different cardiomyopathy, like hypertrophic cardiomyopathy patients. If there is posterolateral late gadolinium enhancement and there is concentric left ventricular hypertrophy and low native T1, the diagnosis will favor Andre Fabry disease. Likewise, it has different pattern in different cardiomyopathy. So this is the genetic architect for the cardiomyopathies. There are different panel A, B and C. Panel A is recommended for autosomal dominant Mendelian inheritance with complete penetration. And if the autosomal dominant but there is incomplete penetration, or in those panel B is recommended, or for sporadic multifocal disease, panel C is recommended. So genetic testing in cardiomyopathy, it requires for patients and for family, relatives, or mainly first degree after diagnosis in proven. So it helps in diagnosing the case, in prognosis, in therapy, and even for the reproductive advice. So genetic testing is recommended in patient fulfilling diagnostic criteria for cardiomyopathy, not as a screening tool. So genetic testing, and it is recommended that cascade genetic testing with pre and post test counseling, because it involves 2 to 3 generation. So it is not routinely indicated, only for diagnosing, establishing pre and post test counseling. So cascade genetic testing in children, a patient-centered approach is must. So if we have started genetic counseling and patient decline genetic counseling, then only continue clinical screening, because genetic testing is also, very costly nowadays. It requires 20,000 at least with different panel. Undergo cascade genetic training, and if genotype is positive, continue clinical screening and risk development. If genotype negative, release for further clinical screening and remove unnecessary worry. So pre-test counseling is very important. Likewise, post-test counseling is very important, and involves family, friends, psychologists. So general principle in the management, we have to manage the symptoms. Main symptom are heart failure with HOCM, LVOT obstruction. We have to take care of LVOT management, and we have to decrease the incidence of sudden cardiac death. So heart failure, arrhythmia, management of ventricular arrhythmia, device therapy, and routine follow-up for patients with cardiomyopathy. So this is the algorithm for appropriate family screening and follow-up. So genetic testing in proband, genetic test result, if there is pathological or like pathological variant is there, we have to further proceed to establish the diagnosis. And if there is no variant, there is no need to go for repeat testing. Psychological support in patients and family is recommended, and that is class 1, level of evidence B. Regular, this is very important slide, because the regular low or moderate intensity exercise is recommended in all able patients with cardiomyopathy of any type. All individual risk assessment for exercise perception is recommended in all patients with cardiomyopathy, but not very strenuous exercise is recommended, particularly in ARVC and LVOT variant of hypertrophic cardiomyopathy. To summarize my talk, the European Society of Cardiology recommend a multi-parameter approach that integrates phenotype assessment, etiological investigation, genetic counseling, and individualized management based on best available evidence. Added new fifth phenotype, that is non-dilated left ventricular cardiomyopathy, apart from HCM, dilated cardiomyopathy, restrictive cardiomyopathy, and ARVC. Each phenotype is further subgrouped into familial and non-familial form with consideration of genocopies and phenocopies. A phenotype first systemic evaluation is emphasized. Thank you.
Very elaborated and nice talk by Professor Ashok Kumar regarding cardiomyopathy, classification, approach and management. Questions invited from audience side.
Sir, should cardiac MRI in genetic testing is advocated in every patient of cardiomyopathy or in some selected patients?
No, in some selected cases. And before genetic counseling, it is always better to have this cardiac MRI, because you will be able to uh, quantify or classify between genocopies and phenocopies. Many a time you will see phenotypically different presentation with genotypically different gene involvement. In those situations, a cardiac MRI is very good tool to subclassify this.
Is there still any role of cardiac biopsy?
Definitely, cardiac biopsy has definite role in establishing the diagnosis, but the evidence is class 2 B. Why so? Because you will need some expert like you to do endocardial biopsy, and even if we are able to take the biopsy, you will very difficultly find the pathologist who will report, and the diagnostic criteria is not very clear in even diagnosing myocarditis per se. Thank you.